Good afternoon. Welcome to do today's Grand Rounds presentation. Please remember to sign the attendance record, and also please remember to fill out the program evaluations, and please give us any ideas that you might have in regards to future topics and future speakers. Topic of the presentation today is healthcare reform, improving quality, reducing cost, and we're fortunate enough to have an in-house expert today. Our speaker is Dr. Mike Kitchell. Dr. Kitchell is board certified in neurology, and he's the medical director of the rehabilitation unit, MGMC. But more pertinent to today's topic, he's the past president of the Iowa Medical Society and also nationally recognized authority on healthcare costs and issues pertaining to healthcare reimbursement. And I'm very pleased that he had the time to talk to us today. And please join me in welcoming Dr. Kitchell.
So you've heard me talk on topics like this before, and one thing I'm not going to talk about today are the GPCIs, the Geographic Practice Cost Indexes. Some people at the American Medical Association think I'm the gypsy guy, so I'm trying to downplay that these days. But what I am going to talk about is what our healthcare future is going to look like, and is there anybody here who thinks we can continue to have our healthcare costs go up at a rate of about 5 to 8% per year? If anybody thinks we can keep doing that, if our stock market or our retirement income went up 8 to 9% per year, we'd be in great shape. But unfortunately, that's how much healthcare costs have gone up. The average premium for a family here in Iowa right now is $14,000 per year. So if you have a family of 4, that's what the premium costs are. Now, the employers generally pay about 3/4 of that. So you're thinking, okay, I'm spending about $3,000 to $4,000 per year on healthcare premiums. That's because employers pay most of that. So most Americans don't really see the costs of health care. The problem that I think is really going to be a bigger issue in health care is who's going to pay for the people that are sick. You've heard about the mandate the Supreme Court is going to decide should healthy people be forced into buying health care insurance. And of course, if you're healthy, you don't want to pay a high cost for a premium. But unfortunately, if we don't have healthy people buying premiums, just like if we don't have people whose houses don't get hit by a tornado, the people whose houses get hit by a tornado won't have coverage. So we've got to have some healthy people buying insurance to make the rest of the insurance affordable to take care of those sick people. How expensive are those sick people? We're spending about $2.5 trillion per year, $2.5 trillion per year on healthcare costs. Half of those costs are spent on the sickest patients. That is about 5% of the population, or about 15 million Americans. So take that math, and it works out to $83,000 per patient for those 5% of the sickest of the sick. $83,000 a year for the sickest of the sick patients. So the question, of course, is can we afford all of these sick people? And how are we going to make sure that we have enough money for schools, for roads, for other things that we want in our communities? Now, Don Berwick, I presume most of you know Don Berwick was the former CMS administrator who's now in a not-for-profit group in Washington. He's still advocating for changes in health care. He believes that about 30% of the costs in health care are wasted. And people say, well, how is that? Well, in some areas of the country, like McFarland, Texas, or Miami, they're spending 2 to 3 times as much per patient as we spend here in Iowa. And if you think we take pretty good care of patients and we have pretty good quality, that's exactly the point that Don Berwick is making. We don't need to spend 2 to 3 times as much as we're spending here in Iowa. So I'm going to talk a little bit about how do we improve the quality and the cost of healthcare. The quality is the numerator, the cost is the denominator. If you reduce cost, you increase value. If you increase quality, you increase value. So most of you know that the relative value unit system is how physicians are paid. In other words, it's fee for service. You get so many dollars per RVU unit. And hospitals for a number of years have been paid for diagnosis. That is the DRGs, diagnosis-related groups. And then I think you know that right now, no matter how good the outcome or how bad the outcome is, it doesn't make any difference in the payment rates. Our healthcare system, too, is made up by a lot of fragmented episodes or different providers of care not working together in a coordinated manner. And most of you know that there's been a lot more emphasis on quality and patient safety. It used to be that that was driven by the fear of lawsuits, but I think most of us here know that that's not the reason that we're making some of these changes in the way we do patient care. So, as I was saying, there are payment changes coming. The delivery of healthcare is changing. The 3 main emphases of the Center for Medicare Service over the past 2 years has been what's called the 3-part aim: better care, better quality, better health of the population, and lower costs. So this has been not just a governmental push to improve quality, improve health, and reduce costs. This is what the insurance companies are now taking up as well. So if, again, we reduce the costs, we improve the value. If we increase the quality, we increase the value. So in the future, we're going to have more measurement and payment for quality, either the processes, like did you give the patient the right antibiotic at the right time, or the outcome. What was that patient's blood pressure? What was that patient's hemoglobin A1C? There are what we call risk group categories. That is, physicians right now are not paid more to take care of sicker patients. Hospitals are paid more to take care of sicker patients. But in the future, that risk category, that means the sicker the patient, the higher the risk of more sickness or more expense, is going to be more and more important. So I've said this before, especially when the government, when the politicians are threatening 27 to 32% cut in physician pay for Medicare, that we can't expect that we'll continue to keep on going up with the dollars per relative value unit. In other words, the amount of work that we do, the volume of the work that we do will not be paid at a higher rate. It might stay the same, it might even go down. Now, how many of you are familiar with the medical home? Do you know what I'm talking about with the medical home? Okay, primary care physicians and their team, that can be nurses, receptionists, health coaches, other people involved with a team approach to make sure that the patient gets the right treatment. It's comprehensive. It means they have enhanced access, and it's over a long period of time, and it's more personalized, it's more patient-centered. Now, the medical neighborhood is what I hope and think that McFarland Clinic will become. It is basically an integrated group with many different specialties, many different types of providers, all collaborating to improve quality. And in the future, there will have to be more collaboration, not just physician to physician, but all along the continuum. The nurses, the other support staff, the hospitals, and so on. So this is called the clinical integration approach, or some goals to improve the care of the patients by coordinating their care and having incentives, that is, the hospital, the physicians, every member of the team knows what the goal is. They align those incentives to improve the care of the patient. Now, most of you know that Iowa has traditionally had very high value. That is, our quality ratings by various different agencies, the Commonwealth Fund, Dartmouth, the Agency for Healthcare Research and Quality. Those ratings in Iowa show that we're in the top 2 to 6 states for quality. And if you look at the overall rankings of healthcare for states, the Commonwealth Fund actually rates Iowa as #1 in the nation for child care, and we are second, tied for second, for adult care. So again, we've had high value here in Iowa. We have low costs, we have high quality. Now, in the last few years, hospitals have been getting some increased payments for what's called value-based purchasing. Those quality measures result in higher payments, and about 2% of Medicare payment now depends upon that value-based purchasing. In the future, in fact, this summer, many of you know that the hospitals are not going to be paid if their readmission rate is very high. So there will be an emphasis on reducing the readmission rate, particularly in those high-cost Medicare patients. Now, many of you know that physicians have had this quality reporting system. It's PQRS, and we actually got paid to report the quality measures in the PQRS program. We got paid to do e-prescribing. Wellmark, for our primary care physicians, has also been paying for quality and paying for performance. There's also meaningful use for hospitals and for physicians, that is, using an electronic medical record in a meaningful way to improve the quality and the collaboration and the coordination of care. That's going to be an improvement for the patients. So over a 4 or 5 year period of time, most physicians, not every physician, if you are using the electronic medical record meaningfully, the physicians will get paid $44,000 for Medicare, and the pediatricians, who see a lot of Medicaid patients, will be paid up to $63,000 over that 4 or 5 year period of time. So what that means for McFarland Clinic in 2012 to 2016 is not small potatoes. It's about $6 to $7 million that we expect to be paid for that meaningful use. Now, as I was saying, value will be rewarded in the future, and the way that you need to look at this is physicians will be paid to keep people healthy, keep them out of the hospital, increase the use of generic or cheaper medication, reduce the total costs of care. I got a report card from Medicare recently, and I found that my professional costs for seeing my patients amounted to 2.3% of the dollars that Medicare spent on those patients that I saw. My professional charges were 2.3%. So if I did a better job of reducing those total costs of care, about $9,000 per patient, I got paid $220 to take care of the average patient. So I got paid 2.3% of what Medicare had to pay for all those patients. Now you may say, okay, but how about the other doctors? Well, if you look at the average, it's going to be about 12%. So in other words, what percent of the Medicare dollars are spent on physicians? It's about 12%. So if physicians can reduce that other 88% of those costs for pharmaceuticals, for durable medical equipment, for hospitalizations, for therapy, et cetera, et cetera, et cetera. That's where the healthcare system will actually reward physicians for doing a better job. So as I said, the hospitals currently have a payment system that's based on the sickness level of the patients. In other words, the hospital gets paid more for a stroke than it does for an appendectomy. Those payments, though, are going to change. Like I say, that will be for physicians, not just hospitals, but for physicians will be based on diagnosis. In other words, the sicker patients, physicians get paid more. So in other words, it won't just be volume of services, how many times did you see the patient, et cetera. It may actually be just a global overall capitation type of fee. Capitation means so much money per patient. So as I was saying, those are non-RVU ways of paying physicians. Those methods, and I'll talk about some of them in the next few slides, those are changing to reflect the fact that it's not going to just be pay for volume or fee for service. It's going to be paid on other strategies. So as I said, McFarland Clinic got some money for pay for performance. Bundling is a new type of payment where if a patient, for example, came into the hospital for a knee replacement operation, there would be one payment for the hospital and for all the doctors, whether it's the orthopedic surgeon, the anesthesiologist, the hospitalist, any consultants, and so on. There would be one fee. Just like a DRG, there would be one fee. So the physicians have to figure out who gets what. The hospital and the physicians have to figure out who gets which half or the other. Shared savings is now a popular way of paying accountable care organizations. That is, an entity like a multi-specialty group in a hospital system would agree to a budget. For example, if the hospital and the physicians last year took care of 30,000 patients and it cost $100 million to take care of those patients last year. That's how much the hospital and the doctors got paid last year. The insurance company would say, we'll give you $102 million this year, so use the money wisely. And if you only spend $99 million instead of $102 million, you get to share some of those $3 million worth of savings. That's the shared savings that I'm talking about. So that's, again, a popular model. 2/3 of the physicians in Massachusetts are signing contracts for the shared savings type of programs. In other words, they have a budget that if they go over that budget, they lose some of that money. If they go under that budget, they get some shared savings. Capitation, as I said, just simply pays so much per patient, and that's, of course, adjusted with the risk, that is, how sick the patients are. In other words, if you're a primary care provider and you're taking care of somebody with asthma, diabetes, and some other chronic diseases, you would get paid more to take care of that patient than if they were perfectly healthy. So as I was saying, the non-RVU payments are going to be more and more prevalent in the future. This is not just a government type of program. Insurance companies all over the country are entering into these type of agreements with physicians and hospitals. So what does getting paid so much money per patient, capitation, what does that mean? What does the shared savings mean? In other words, if it's a $100 million budget, next year you get $102 million, you're at risk if that budget goes to $103 million or $104 million. The physicians and the hospital have to pay back. They are at risk if they use too much money to take care of those 30,000 patients that they took care of last year. So in other words, if the costs are higher, the providers make less income. So that's something the insurance companies like, because now they're not at risk as much because the hospitals and the doctors are more at risk for those excessive payments or that increasing cost of care. So I have a really basic question here. Politicians are kind of getting involved with this question too. Who out of these three categories do you think should limit the cost of care? You know, some politicians want more skin in the game. They want to have patients who come to the doctor's office and say, "Doc, I've got a backache. I want a magnetic resonance scan on my back." And of course, if there's skin in the game, the doctor says, "Well, your insurance company says if you want a magnetic resonance scan on your back, you got to pay 20%. Well, doctor, do I really need that MRI scan? So that's the way that we can limit some of these costs. You just simply say, well, if you don't have an indication for that magnetic resonance scan, you pay 80%. Now that's really putting some skin in the game. So again, what are some of the ways that we can reduce costs? Most countries limit costs by simply saying the payers only pay so much for a doctor visit or only pay so much for a procedure, or they simply say that's not covered by the Canadian health insurance plan. So that's what some people call rationing. So the government can reduce what they pay providers, the government can restrict, shorten the menu of things that are available. So which of these three things will be more likely in the future? I think all three of these strategies will probably be used. One of the issues is, of course, do you want the patients deciding whether they need some complex treatment for their cancer, or do you want the physicians counseling with the patient to decide what is the best treatment? And this is where the accountable care organizations, or the HMOs, have really been the insurance company's preferred method of restricting some of the costs that are going up. Now, people always ask me, what's the difference between an accountable care organization and an HMO? Well, an HMO is usually an insurance company that runs a program, but there are some physician groups like Kaiser Permanente that actually are hospitals and physicians, and they have their own insurance plan, and it is an HMO. But really, what's the difference between an ACO and an HMO? An ACO has their payment dependent upon quality measures, on performance of patient satisfaction, and so their payments are at risk, not just for cost, but their payments in an ACO are at risk if they don't meet certain quality criteria or if they don't meet patient satisfaction standards. What's another way that the ACOs and HMOs are different? HMOs restrict patients. They fence them in. So if you have an HMO, they're going to say, you can't go see that other specialist down the road. You're restricted to the HMO providers. An ACO does not have a fence. The ACOs have to either have greener pastures so people don't jump into the next field, or they have to have stickiness. The ACOs have to make the patients more engaged in their care, be happier, be satisfied with their care, so they don't go down the road and get some expensive treatments from a different specialist. So I do want to talk a little bit more today about some of these quality and cost measures. At McFarland Clinic, we've had over 5 years of Wellmark paying our primary care physicians for quality and performance. We've also had 5 years of Medicare that has paid both our specialists and primary care doctors. And like I say, with the meaningful use, most of our physicians will have the opportunity to get some payment for that. And as I said earlier, I've looked at my own report card. Medicare in March, just last month, sent out individual report cards, they're called QRUR, to physicians. And in the past, Wellmark has paid McFarland Clinic over a 5-year period of time $3.4 million because of our high performance. Medicare has paid us about $3 million in bonuses for what we've done well. And we're one of only 10% of the physicians in this country that have succeeded with the PQRS program, with the Physician Quality Reporting System. So I think that's a tribute to a lot of people doing things well here. Now, this report card that I talked about for individual physicians, we just got that in March. We actually received our group report card last September. We were one of 35 groups in the country who voluntarily reported quality on the basis of group reporting. So we were in a select group of 35 physician organizations around the country, including Mayo Clinic, Cleveland Clinic, Mass General. The University of Iowa actually participated in this too. And those 35 groups, we were the first ones to receive these report cards. They measured our quality. They showed us what the cost per patient was. That's where I gave you those numbers. My own individual numbers, we got those same numbers for McFarland Clinic. And those cost categories were total cost per patient and 4 major costly disease categories. So like I say, in March, those individual report cards, like I received mine, Steve Hallberg received one. We got 41 different quality measures that we were reported on. Virtually none of these were neurologic quality measures. These were mostly primary care or preventive type measures. So I got credit for a lot of primary care physicians' high performance, but I was very happy to take credit for the high performance of our primary care physicians. And then again, as we knew from last fall, McFarland Clinic's cost per patient was some of the lowest in the country. We actually saved Medicare $32 million in 2010. $32 million. We didn't even get paid $30 million by Medicare. So we saved Medicare more than they actually paid us, because we saved money on Medicare, not just on physician costs. We saved money for Medicare by not putting people in the hospital as frequently. We didn't have as many ancillary treatments. We didn't have other costs of health care like they have in Miami and McAllen, Texas. Now, this report card is actually just a prelude to something that's going to be a national program in 2015. And the scary part about this, not so much for us, but for other physicians, is they are going to use 2013 data. Remember, I said our report card was from 2010. That's 2 years ago. And so when they start to pay physicians in 2015, they're actually going to have to use not 2012 data, but 2013. So in 9 months, physicians are going to have to be ready to look good on quality and cost measures, because there is payment that's going to be involved with that. So groups that are accountable for cost and quality, are they going to do better than the physicians who don't report quality and who don't really pay attention to cost? You betcha. They'll be, ACOs will have a much easier time in doing well on this. And are America's physicians ready for quality and cost payments? I don't think so, but I think we are. I'm happy to do that. This is why I want to talk about our report card, our group report card, compared to those 35 other groups like Mayo Clinic, Mass General, Cleveland Clinic. Our diabetic and lipid control, that is, what were the LDL levels, what were the hemoglobin A1C levels, our primary care physicians were in the 90th percentile, above the 90th percentile for these two measures. In other words, we were pretty good with how we controlled our diabetics and our patients with hyperlipidemia. Our admission rate for the 4 extremely expensive diseases in Medicare, diabetes, congestive heart failure, COPD, our admission rates were remarkably better than average. Our diabetic admission rate was 1/2 the national average. We hospitalized our diabetic patients 1/2 as often. Congestive heart failure, our admission rates were 55% of the national average, almost half. So our physicians did a great job of controlling their diabetics numbers, keeping them out of the hospital. Same with the congestive heart failure. Our COPD patients were about 75 to 80% as likely to be hospitalized. So again, we're doing a really good job of keeping the costs down while we're also keeping patients healthier and keeping them out of the hospital. Do you think a diabetic appreciates the fact that they're hospitalized half as often if they are cared for by our physicians? I think they appreciate that. They probably don't realize it, but they should appreciate it. And if the patients with congestive heart failure are hospitalized 55% as often, I think they appreciate that too, but we just don't get credit for it, not yet anyway. So again, as I was saying, compared to these other high quality or elite groups, McFarland Clinic did very well on quality measures. So as I said, we saved Medicare $32 million because we didn't hospitalize people as often. We didn't do as many ancillary treatments. We didn't have to have the patient stay in the hospital as long or have as many treatments. If you looked at our cost per patient, we saved Medicare over $2,000 on the average patient. We saved Medicare $2,000 on the average patient. But for the patients that were the sickest, like with congestive heart failure, we saved Medicare $5,700 per patient and $5,200 per patient per year for the COPD patients. So again, if we have some shared savings, what percent of that 32 million should we get in shared savings? I'll take it. The problem is the shared savings programs, they don't compare McFarland Clinic to the national average. They compare ourselves to a pretty high standard, ourselves. So that's what the shared savings is. We've got to do better than we did in 2010 to do well in the future. Is there room for improvement? Yeah, we can still do that. We were in the 13th percentile for overall cost, but no group out of that 35 group had lower costs for coronary artery disease admissions and congestive heart failure. So let's give our cardiologists and our primary care doctors a lot of credit for that. Now, as I was saying, Berwick has identified that about 30% of healthcare costs, these are administrative costs, these are costs of doing ineffective or unnecessary care, and so on. How can we reduce costs even further, though, than what we're doing? We need to concentrate on higher cost chronic diseases like what Medicare has. We spend about $30,000 per patient per year for congestive heart failure patients on the average, okay? But they spend far more nationwide than we do here. So to do well in the future, we'll need to prevent expensive complications by managing the care better, just like we're doing with diabetes, COPD, congestive heart failure. We have to avoid what are called potentially preventable costs. And again, some of those major diseases are the big ticket items, the really expensive things. We actually got rated by Medicare too on bacterial pneumonia, urinary tract infections, and dehydration. And I wonder how we could have avoided urinary tract infections. What can we do better to avoid urinary tract infections? We didn't. We were about the national average for urinary tract infection admissions. We were about the average for dehydration. We're actually just a touch above, not statistically significant for bacterial pneumonia. But again, overall, we did extremely well for preventing those expensive and chronic diseases. So how do we do better? We again need to use the electronic medical records to get meaningful data. Our electronic medical record actually automatically reports these quality measures now. It's embedded in the electronic medical record, so our physicians don't have to check the box. Our physicians don't have to click. Those measures go directly in to be reported. And then, as I said earlier, we need to partner with each other and with hospitals to reduce those readmissions and complications. There's a program called Partnership for Patients that is also part of the Iowa Healthcare Collaborative, and Mary Greeley has been very active with those quality improvement strategies through the Iowa Healthcare Collaborative, but the national strategy is called Partnership for Patients. Now, for physicians, I think our real challenges are to improve quality, improve our patient outcomes, and we need to look at those chronic major diseases and, again, demonstrate our value, and that's where the tool of our electronic medical record is going to help us a lot. We need to develop competencies in using those tools, getting the feedback from an electronic medical record to improve those care processes. For quality measurement now, there are over 750 quality measures. Now, not all of them are good, but as I was saying, some of these are processed, for example, giving antibiotics, giving aspirin, giving beta blockers, and so on. Some of these are outcomes, like what was the blood pressure level, what was the LDL level. So outcomes as well as process measures are being measured constantly now, and those measurements are continuing to evolve. There are going to be better measures and obviously more measures too. So the prediction is fee-for-service, that is dollars per RVU, won't go away. You're still going to, physicians are still going to need to be paid more for more work. I mean, like, how are we going to get physicians to work if we don't pay them for more work? But it won't be the same type of work. It'll be not just that RVU treadmill that physicians are trying to run as fast as they can on. There will be other processes that we need to improve. Now, as I said, this is not just a government conspiracy to have accountable care organizations. People say, well, this is kind of like the Clinton healthcare plan in 1995. It'll all go flat and it'll all go bust, and we'll have some new politicians that'll completely change things. Well, these are insurance companies that are changing, and if you know the politicians, some of the politicians actually want to give more power to insurance companies to run healthcare, and so it's definitely coming no matter who's in political power. Wellmark has actually had 3 large physician organizations in the state sign an accountable care contract. Just like I said, 2/3 of the physicians in Massachusetts are now working under these accountable care organization contracts. California also has a lot of physician groups that are doing this. And Medicare currently has many accountable care organization options for us. We've been a little reluctant at McFarland Clinic to do that because, like I say, that $32 million that we could have shared in savings, we're not competing against the national average, we're competing against ourselves. So can we do better next year than we did this year? The first thing we've got to do is make sure our diagnosis coding is correct so we get credit for taking care of all those sick people that we might not have gotten credit for because we don't diagnose as much as those Miami physicians do. Now, I think many people know that some specialists are called partialists. If you're a primary care doctor, I'm sure you've had that idea that you get a specialist and they just want to do that and then they split. And so that's what we call a partialist. They only take up partial care of the patient. And that's where I think most accountable care organizations rely upon the primary care physicians to take comprehensive care of the patient. I also think, though, that a medical neighborhood is even better than a medical home, because if you've got the primary care physicians working very closely collaborating, coordinating care with a specialist like we do at McFarland Clinic, that's where you're going to have better results. There are gaps in care where patients don't receive that right care. Sometimes when the patient is done with their RVU, they leave, and then who is the person to pick up the care? So there's sometimes a lack of ownership for that patient problem, lack of responsibility to follow through, and that incomplete or ineffective care in Miami or McAllen, Texas is why it's so expensive to give poor quality care. So again, we've got to be more patient-centered and maybe a little less provider-centered. I think we need to take a team approach, just like the medical home models have taken a team approach, and then the medical neighborhood is even a better improvement on that. So my prediction for the future is to retain autonomy, because physicians really don't like to have some other entity like an insurance company or the government telling us what to do or how to do it. But to retain autonomy, we have to be more accountable. And we will be held accountable not just for quality, but for those outcomes of the patient and the cost. And again, the way to succeed is, again, to use those tools that we have, the electronic medical record and the team-based care. In other words, this can't be a burden that we just put on the physicians' backs. We need nurses, we need other support staff to help us to take care of these patients and coordinate and communicate better. So as I said, the meaningful use will have embedded quality measures, so you don't want to have the physician keeping track of all this stuff or keeping track of when the patient needs to come in for their mammogram or their colon exam or whatever. And the EHR, the electronic medical record, is essential for that type of value measurement and improvement. So in the future, there will be more teamwork or integration of physician and other support staff care. We will have to have more patient-centeredness and a better medical neighborhood. We'll have to engage our patients. If our patients are compliant and adherent, we'll have better results for everyone. And then we do need to improve efficiency because reimbursement will not get any better. So to summarize, payment reform will reward increases in quality and it'll reward lower costs. If you have a better idea on how to reduce costs, we'd love to hear it, and the politicians would love to do it. But again, I think no matter what happens with the ACA law or Obamacare, there's going to be more emphasis on quality and reducing costs, and there will be more skin in the game for patients, but there also will be more responsibility on the providers to reduce those costs. And if we can cut out the fat, if we can keep doing what we're doing well by keeping people healthy, keeping people out of the hospital, you know, some of that $32 million that we saved was actually some money that Mary Greeley didn't get paid because they didn't have to be in the hospital as often. So Mary Greeley is perfectly willing and ready to do what is necessary to keep those people healthy and keep those readmissions down. So I know Mary Greeley has a new program for transitioning care to make sure those patients, when they get discharged, don't fall through the gaps in care, and the primary care physicians will pick them up quickly and keep them healthy, keep them from being readmitted. So again, I think we can succeed with pay for value using those tools and using that teamwork that I talked about. So I will answer any questions, and even if you have a few political comments, I'm fine with that. So.
Were the results of the 35 groups, are they available online, or were they only reported to the groups involved?
Yeah, the question is those 35 groups that were in the group practice reporting option, the report cards for the groups, we did not get to see anybody else's report card. The only reason I'm allowed to share that is I can share those figures if it's in the context of improving quality and improving value. So I'm telling you these things because I want to motivate everybody to think about being paid for value. But we don't know what Mayo Clinic did. We don't know what the University of Iowa did. So.
Dr.
The question was, with the shared savings, if you improve every year and you reduce your costs every year, how do they reward you for that continual improvement? And that's a good question. If we cut out that 30% of the fat in the system, we're going to get down to the bone. So there is going to be certain costs that we just can't get any lower than. And so there has to be some sort of inflationary kicker. The question about that, you know, if it's a $100 million budget and we made $99 million this year, are they going to make it $99 million next year? No, there's going to be an inflationary figure. And Wellmark was talking about CPI, and CPI is like 1%. Medical inflation is going up 5 to 8% per year. So it's probably going to be something like a 3% inflation that's built in. Like I say, if you try to cut and cut and cut, you're definitely going to reach bone. We're going to reach bone quicker than Miami is. They're the ones that are going to really benefit from this shared savings program. I listened to a presentation at the American Medical Group Association from a bunch of Boston physicians, and they were really happy with this because even though they're high quality in Boston, they're also very high cost. So they're going to benefit a lot more than we would benefit by these ACOs. And that's where Massachusetts, like I say, 2/3 of the physicians are getting in there. So there's an inflationary increase even in Massachusetts, but it varies with the insurance company as to what that is. It going to be 3%? Is it going to be 5%? Is it going to be 1%? We just didn't think 1% was doable. So. Correct, yeah. So again, the question was, we're basing things on past performance. Can you do better than you did in years past? I would regard, though, for example, our diabetic admission rate was 1/2 the national average. I would give our physicians 20 years ago for a lot of the credit, because those people are 75-year-old diabetics who had diabetes at age 50 or 60, and because those physicians 20 years ago took good care of them, they avoided a heart attack, they avoided a stroke, they avoided peripheral vascular disease, and so on. But again, the question is, will we be penalized because we've been so good in the future, and are we going to continue to be cut as far as our payments are concerned? That's why I favor some sort of national standard for paying for value, not shared savings on your own past performance, because can you keep doing continually better and better and better? Patients get older every year too, and if you keep them alive, then you're going to have a lot of 95-year-olds with, you know, congestive heart failure, and you're going to try to keep them healthy and keep them out of the hospital. So every year it gets harder and harder. The people in Louisiana who die off early and they have their strokes at age 55, they never make it to Medicare, you know, so that's part of the problem.
Kind of specific question here. For some obscure reason, Medicare does not cover for IV antibiotics at home and prefers to keep people in skilled units. So 2 questions regarding that. I mean, can you elaborate on how the hospital loses money and how much with that kind of system? And also, is that kind of arbitrary deliberation anticipated to change in future years? I mean, this specific case and in general similar cases, right?
Yeah, obviously I don't need to repeat your question. Those payment decisions by Medicare are definitely arbitrary. Some bureaucrat made those decisions. And if we were an ACO, I'm sure we would simply say, we're going to make some arrangements for home antibiotics, for home IV treatment, because it's cheaper and we can show that we can ensure the quality. Medicare underpays for skilled care. Medicare underpays for a lot of other things. and Medicare overpays for some things too, but that's really the issue. If you have local control and local ideas on how to save money, the ACO model would allow that to be done, because again, you'll be given a capitated dollar amount, and then this is why the insurance companies are paying for some of these home infusions, but Medicare's not. So again, Medicare pays so little for some things, and then doesn't pay anything for home infusions. They won't even allow it. So it's not a cost-effective decision, but again, it's a decision that a bureaucracy makes.
The report card you received, did it include McFarland clinics around the state or just here in Ames?
Yes, the McFarland Clinic report for the group practice reporting, as well as the individual physician reports, is for the entire McFarland Clinic. I looked at some of our individual results from Carroll, Marshalltown, Webster City. Very, very, very similar. In fact, that's what we found from Wellmark. Our Marshalltown physicians, for example, did extremely well with Wellmark as well. So it's I've actually had a University of Iowa professor tell me that we did such a good job here because all our patients are Iowa State faculty, and they're all very compliant and adherent to the things that we do, And I said, well, okay, but we do the same good job in Carroll and Marshalltown, and so it's not just Iowa State faculty. What? Oh, yeah. Well, the University of Iowa blames all their problems on the people who come from all over the state, so. Well, thanks for your attention. I hope I stirred up a little bit of thinking. And next time you hear the politicians, just think the 5% of the sickest of the sick, they cost $83,000 per patient per year. And who's going to pay for those sick people? That's going to be a struggle.